Welcome to Sticky Med, learning medicine, stick by stick.
We begin with MN1, best way. So it introduces a 35-year-old man. He's suffering from recurrent, pretty severe peptic ulcers, and he also has a history of kidney stones. Now, his key lab results: serum calcium is high, 12 mg/L. His parathyroid hormone, PTH, is elevated. And critically, he has highly elevated gastrin levels. The question is, what single genetic mutation is the root cause here?
Well, this specific triad, the high calcium, the kidney stones, and that aggressive peptic ulcer disease, I mean, that's pretty much the textbook definition of multiple endocrine neoplasia type 1, or MN1.
Right, the classic 3Ps.
Exactly. You look for the 3Ps, parathyroid hyperplasia that's causing the hypercalcemia and the stones. Then pituitary tumors, although they aren't explicitly mentioned here, they're part of the syndrome. And finally, pancreatic tumors.
And the pancreatic tumor explains the gastrin.
Precisely. The high gastrin tells you he has a pancreatic gastrinoma that causes Zollinger-Ellison syndrome, which is notorious for those really refractory ulcers. So putting it all together, the responsible genetic defect is answer B, the MEN1 tumor suppressor gene on chromosome 11.
Okay, a tumor suppressor gene. So that means the inherited mutation needs a second hit, right? A loss of function to actually cause the tumor?
That's correct. It's a loss of function mechanism. But what's fascinating is how incredibly distinct this is from other multisystem genetic disorders. You asked why it couldn't be, say, option A, von Hippel-Lindau disease, the VHL gene mutation.
Yeah, VHL involves endocrine tissues too sometimes.
It does, but the distinction lies in the target organs. While VHL can involve pheochromocytoma, which is endocrine, its real signature findings are things like retinal and central nervous system hemangioblastomas, and very notably, renal cell carcinoma. VHL doesn't classically hit the parathyroid, and crucially, it doesn't involve that pancreatic gastrinoma you need to explain the high gastrin and the ulcers in our patient.
Okay, that's a clear line in the sand. Now, what about option C, neurofibromatosis type 1, the NF1 gene? Does that ever cause endocrine issues like this?
It can, but differently. NF1 is mostly known for the skin stuff, right? The neurofibromas, the café au lait spots. But it is associated with a, let's say, modest increase in the risk of pheochromocytoma.
But not the MN1 triad?
No, absolutely not. It simply doesn't cause those three specific tumors needed for the MN1 diagnosis: parathyroid, pituitary, and pancreatic. You're completely missing the whole hypercalcemia and gastrinoma piece.
Got it. And option D, the PRKAR1A mutation leading to Carney complex. What does that look like?
Carney complex is pretty rare and very specific. It involves unique heart tumors, called myxomas, and specific endocrine tumors. Usually, it's primary pigmented nodular adrenal disease, which often presents as Cushing syndrome that's independent of ACTH. So again, structurally, genetically, it's just miles away from the MEN1 picture we have here.
Okay. And finally, we can definitely eliminate the RET proto-oncogene, option E, because that's the hallmark of the MN2 syndromes, right?
Precisely. And notice the difference. RET is a proto-oncogene. It's a gain-of-function mutation that actively drives tumor growth. That's biologically quite distinct from the loss-of-function mechanism we see with the MN1 tumor suppressor gene. And this genetic difference really drives the different symptoms we see in MEN1 versus MEN2.
We've got a 28-year-old woman, strong family history of thyroid cancer. She's presenting with these episodes: headaches, severe palpitations, sweating. Her labs clinch it: elevated plasma metanephrines and, of the big one, elevated calcitonin. We know this points to N2A. The question is, what is the third and most likely associated finding?
Yeah, this case is a fantastic example of just recognizing the pattern clinically. Elevated calcitonin, that's your definitive marker for medullary thyroid carcinoma, MTC. Elevated metanephrines, that's the sign of pheochromocytoma, causing all those spells: the headaches, palpitations, hypertension.
So MTC plus pheo equals MN2A. What's missing?
The third common component, the one that completes the M2A triad, is answer B, hyperparathyroidism due to parathyroid hyperplasia.
Oh, okay. So this really confirms that major distinguishing feature between the two main MNN syndromes. Both can affect the parathyroid, causing hyperparathyroidism. But MN1 hits the pancreas and pituitary.
Well, N2A hits the adrenal medulla, that's the pheo and the C cells of the thyroid, giving you the MTC.
And this makes eliminating the other options really straightforward, doesn't it?
Absolutely. Look at the other choices. Option A, pancreatic gastrinoma. Option C, pituitary prolactinoma. D, insulinoma. E, acromegaly. What do all these have in common?
They're all classic tumors of MN1.
Exactly. If you, as a clinician, see confirmed MTC and pheochromocytoma from the labs, you would immediately dismiss this entire list of MEN1 tumors. They just don't fit. The underlying molecular signatures, the RET versus the MEN1 gene, they're fundamentally incompatible.
Got it. Okay, let's switch gears now to a different kind of life-threatening genetic defect, this time involving enzyme deficiencies right in the adrenal cortex.
Ah, yes. Congenital adrenal hyperplasia.
There's a 3-week-old female infant presenting in crisis. She's vomiting, severely hypotensive, and has ambiguous genitalia. Her labs show a really dangerous electrolyte imbalance. Sodium is low at 125, potassium is high at 6.5+, a markedly elevated 17-hydroxyprogesterone, or 17-OHP. Which specific enzyme is missing here?
This constellation of symptoms, the salt wasting, which is the low sodium, high potassium, hypotension combined with low cortisol, and the high androgens causing the ambiguous genitalia in a female infant. This is the most common and frankly the most dangerous form of CAH. The core defect is answer E21 hydroxylase deficiency.
Okay, we really need to spend some time on this pathway because understanding the differences between this and the wrong answers is literally life or death for these infants.
Yeah.
Let's start with the physiological reason this baby is crashing so hard.
Right. The 21-hydroxylase enzyme is absolutely indispensable. It acts at two crucial points on that steroid synthesis map in the adrenal cortex.
Okay, right.
Well, first, in the zona fasciculata, it's needed to convert 17-OHP into the precursors that eventually become cortisol. Second, down in the zona glomerulosa, it's needed to convert precursors into aldosterone. So when 21-hydroxylase is deficient or completely absent, three things happen all at once.
What are they?
1. Cortisol deficiency. The baby can't make cortisol. This leads to massive stress intolerance, difficulty maintaining glucose, and contributes significantly to the hypotension.
Okay, no cortisol.
2. Mineralocorticoid deficiency, which means salt wasting. The baby can't make aldosterone, which is our main salt-retaining hormone, so the kidney just dumps sodium and holds on to potassium. This causes that severe salt wasting, the dehydration, the hypotension, and potentially shock.
That explains the electrolytes and the low blood pressure. What's the third piece?
And 3, androgen excess. Because the pathways to cortisol and aldosterone are blocked, all those precursors, especially the 17-OHP, they get massively shunted sideways down the androgen pathway. This flood of androgens causes the virilization, the ambiguous genitalia we see in female infants. And that markedly elevated 17-OHP level, that confirms the block is right before the 21-hydroxylase step. It's building up.
That paints the complete, very dangerous picture. Now, let's use the wrong answers to map out the rest of the CAH spectrum. Why doesn't option A, 11-hydroxylase deficiency, fit this case?
This is probably the most critical distinction to make clinically in CAH. If you're missing the 11-hydroxylase enzyme, you still get cortisol deficiency, and you still get androgen excess. So the baby might still have ambiguous genitalia, low cortisol, but the block happens later in the pathway.
So what accumulates instead of 17-OHP?
Instead of 17-OHP piling up, you accumulate stuff like 11-deoxycorticosterone DOC and 11-deoxycortisol.
And what does DOC do? That sounds important.
It is. DOC, even though it's considered a weak mineralocorticoid, it still acts like one. When it accumulates in large amounts, it acts like a functional excess of aldosterone. So this defect causes the patient to retain salt and water, leading to hypertension and often low potassium hypokalemia.
Wow, so it's the exact opposite of our patient who is hypotensive and salt wasting.
Precisely. It completely flips the clinical scenario regarding blood pressure and electrolytes. That makes 11-hydroxylase deficiency wrong for this case.
That's fascinating. The difference between life-threatening salt wasting and hypertension comes down to whether the precursor that builds up happens to have mineralocorticoid activity or not.
Yeah.
What about option D then? 17-hydroxylase deficiency.
That deficiency is also really distinct. It blocks things much earlier. It blocks the synthesis of both cortisol and all the androgens, the sex hormones, but it leaves the mineralocorticoid pathway wide open, actually shunting precursors towards making more DOC and corticosterone.
So what does that patient look like?
They'll present with deficient sexual development because they can't make androgens, and they'll have cortisol deficiency. But crucially, they'll have an excess of mineralocorticoids causing severe hypertension, often from birth. Again, completely the opposite of the salt-wasting picture we see here.
It really is like pathway mapping. You absolutely have to know the specific function of each enzyme to predict the clinical outcome, especially the electrolytes and blood pressure. Okay, one more. Option B, aldosterone synthase deficiency.
Right, this one is a bit different. This would cause pure salt wasting, low sodium, high potassium because you're missing the final enzyme needed just to make aldosterone. But it's a relatively clean deficiency in that sense. It doesn't significantly affect the cortisol or the androgen pathways,
No.
meaning you wouldn't see the ambiguous genitalia because androgen production is normal, and you wouldn't see that massive 17-OHP elevation that's so characteristic of 21-hydroxylase deficiency. So again, it doesn't fit our case.
Wow, okay. That really clarifies the different forms of CAH. So we've established some genetic roots of adrenal failure. Now let's move further up that hormonal axis, right up to the master regulator, the pituitary gland. We'll look at dramatically different ways it can fail, sometimes acutely from ischemia, other times more chronically from, say, mechanical compression.
Yeah, the pituitary is central, but it's also vulnerable in unique ways.
Okay, 30-year-old woman. She's 3 months postpartum. She comes in with profound fatigue. She reports she never started lactating after delivery, and she hasn't had her period return secondary amenorrhea. Her labs are just flat across the board. Low cortisol, low TSH, low prolactin, and low FSHLH. What single event could cause such a massive global pituitary failure?
The clinical scenario here is almost unmistakable. When you see sudden, complete panhypopituitarism, that means failure of all the anterior pituitary hormones occurring specifically in the postpartum period, you have to think Sheehan syndrome. The underlying cause is, answer D, ischemic necrosis of pituitary postpartum.
I've always heard about the pituitary being particularly vulnerable around childbirth. Can you explain the physiology behind that vulnerability? Why does this happen then?
Certainly. During pregnancy, the anterior pituitary, especially the cells that produce prolactin, the lactotrophs, undergoes this massive cellular growth hyperplasia. The gland itself physically enlarges, often doubling in size.
Okay, so it gets bigger.
Right. But here's the catch. This growth isn't really matched by an equal increase in its blood supply. The pituitary relies heavily on this low-pressure portal venous system for its blood. Now, imagine the mother suffers a severe postpartum hemorrhage, significant blood loss.
Right, a common obstetric complication.
Exactly. The resulting systemic hypotension means blood flow to the pituitary drops sharply. This enlarged gland, with its already high metabolic demands, becomes incredibly susceptible to ischemic damage, basically. It suffers an infarction, a stroke.
And the resulting symptoms perfectly mirror the specific hormones that are lost then.
Precisely. Loss of prolactin means failure to lactate. Loss of FSH and LH means the ovaries aren't stimulated, so you get amenorrhea. And the loss of ACTH, leading to low cortisol, and TSH, leading to low thyroid hormone, causes the generalized fatigue, the low blood pressure, the inability to cope with stress.
The acute nature, specifically tied to that history of postpartum hemorrhage, really makes it diagnostic.
It does. Now let's quickly look at why the other causes of pituitary failure don't quite fit this specific picture. Option A, a pituitary macroadenoma.
Well, a large tumor could eventually compress the gland and cause hypopituitarism over time, right?
It could, definitely. But it usually doesn't present as this sudden acute collapse 3 months after delivery. It's typically a more gradual process. Plus, the most common type of functioning pituitary adenoma is a prolactinoma, which would usually raise prolactin levels, not cause the profound lack of prolactin needed to explain the failure to lactate here.
Okay, what about option C? Autoimmune lymphocytic hypophysitis.
That's a very real thing. It's an inflammatory attack on the pituitary, and interestingly, it's often seen in late pregnancy or the postpartum period. It absolutely can mimic Sheehan syndrome clinically.
So how do you differentiate?
Usually by the history. When the case is directly linked to a history of massive peripartum blood loss, ischemic necrosis, which is Sheehan syndrome, becomes the classic and frankly the most statistically likely diagnosis. The hemorrhage is the key trigger.
Makes sense. And finally, option E, a hypothalamic tumor.
Well, that would cause problems one level higher, blocking the releasing hormones like GnRH, TRH, CRH. This would lead to tertiary hypopituitarism, but it wouldn't really explain the specific acute prolactin deficiency. Prolactin is mainly under inhibitory control from dopamine from the hypothalamus. And critically, it doesn't have that characteristic link to an acute obstetric event like hemorrhage. The location of the problem feels wrong for this specific timeline.
Okay, so we jump from that acute trauma of Sheehan, the classic acromegaly patient. He's a 45-year-old man. You see the typical signs: enlarged hands, prominent jaw, prognostism. His labs confirm it, high IGF-1 levels, and his growth hormone, GH, doesn't suppress when you give him glucose, which it normally should. But the key sign of real danger here is the finding of left ventricular hypertrophy, LVH, on his ECG. What's the most common life-threatening complication stemming from this chronic hormone excess?
Right. The excessive growth hormone and the resulting high insulin-like growth factor 1 or IGF-1, they exert a direct, almost toxic effect on the heart muscle itself. The hypertrophy, the thickening of the heart wall, seen as LVH, it's real, but it's fundamentally dysfunctional growth. So the leading cause of premature death in untreated acromegaly is answer B, cardiomyopathy, leading to heart failure.
I want to focus on that word dysfunctional for a second.
Yeah.
Normally, when we hear about heart hypertrophy, we might think of an athlete's strong heart. But here, the GH is just forcing growth inappropriately. Is the muscle quality itself actually poor?
It absolutely is. The signaling from GH and IGF-1 causes this inappropriate myocardial growth, but it also often leads to fibrosis, scarring within the heart tissue. So while the overall muscle mass increases, that's the hypertrophy, the heart's ability to relax and fill properly with blood, its diastolic function, gets severely impaired quite early on.
And then pumping fails too.
Eventually, yes. Later, the ability to actually pump effectively, the systolic function, also starts to fail. This combination of structural damage, the hypertrophy and fibrosis, and the functional decline leads directly to conditions like restrictive cardiomyopathy, sometimes dilated cardiomyopathy, and ultimately frank heart failure. That LVH finding on the ECG is really the smoking gun pointing towards this specific dangerous complication.
Okay, now let's quickly just eliminate the others to be thorough. Option A, hypercalcemia.
Wrong axis entirely. That relates to PTH and calcium regulation, not GH.
Option C, adrenal crisis.
That's about cortisol deficiency, again, a different pathway, not directly caused by GH excess.
And the metabolic options. Why is hypoglycemia, option E, definitely wrong?
Because GH is fundamentally a catabolic hormone, and it's strongly counter-regulatory to insulin. It actually opposes insulin's action. So chronic GH excess creates a state of severe insulin resistance. The body needs massive amounts of insulin just to try and manage glucose levels.
So acromegaly leads to high blood sugar, not low.
Yes. Exactly. Acromegaly very frequently leads to secondary hyperglycemia or even overt type 2 diabetes. So spontaneous hypoglycemia in this state is physiologically pretty much impossible.
Right. And option D, Cushingoid features.
That would only really happen if the pituitary tumor was a mixed tumor, co-secreting ACTH along with the GH. While that can occur, it's less common than the direct damaging effect of pure GH excess on the heart muscle itself. The cardiomyopathy is really the signature and most lethal long-term consequence of that GH-IGF-1 axis being out of control.
Okay, now for the flip side of that coin. A 4-year-old boy who's presenting with growth retardation. His thyroid labs come back a bit strange. His total T is low, but his free T is normal, and his TSH is also normal. So why would the total T4 be low if the active hormone, free T4, and the pituitary signal, TSH, seem perfectly fine?
This is a really classic pattern, a textbook example of a problem with hormone transport, not a defect in the thyroid gland itself. The solution here is answer A, defect in thyroxine-binding globulin causing low total T but normal free T.
Okay, can you just quickly clarify for us again the difference between total T4 and free T4 and why TBG is so important?
Sure. So the vast majority, over 99% of the T4 hormone circulating in your blood is bound tightly to carrier proteins. The main one is thyroxine-binding globulin, or TBG. When we measure total T4, we're measuring all of it, bound and unbound.
But only the unbound part matters.
Exactly. That tiny remaining fraction, less than 1%, is the free T4. It's the only portion that's actually biologically active, the part that can get into cells and do its job. And critically, the pituitary gland, which releases TSH, only monitors the level of this free T4.
So if this child has a genetic condition causing low levels of TBG protein,
then the total carrying capacity for T4 in his blood drops significantly. So his measured total T4 will look low, but the body is smart. The feedback loop ensures that the amount of active free T4 remains within the normal range to keep things functioning.
and because the free T4 is normal, the pituitary sees everything as okay.
Precisely. Since the free T4 level is normal, the pituitary correctly senses a euthyroid state, meaning normal thyroid function. As a result, it releases a perfectly normal amount of TSH. So the child is actually metabolically normal from a thyroid standpoint, even though the total T4 lab value looks abnormally low. The growth retardation mentioned in the case must be due to something else entirely, not primary hyperthyroidism.
Okay, that really clears it up. Now we can easily eliminate the wrong answers, which all represent true hypothyroidism, right? Option C, iodine deficiency. D, TSH receptor mutation, and E, thyroid peroxidase defect. Why are they all ruled out instantly by that normal TSH?
Because all three of those represent a primary failure of the thyroid gland itself to produce enough T4 and T3 hormone. In every single case of true primary hypothyroidism, the pituitary senses the resulting low free T4 levels and tries desperately to compensate by pumping out massive amounts of TSH.
So high TSH is the hallmark.
Yes. True primary hypothyroidism is always characterized by low free T4 and a highly elevated TSH. The fact that this child's TSH is normal immediately rules out all three of those possibilities.
Okay, moving from potentially misleading labs to clear-cut hyperthyroidism. Question 58 describes a 55-year-old woman. She's got palpitations, weight loss. Labs confirm hyperthyroidism. Her TSH is suppressed way down, and her free TR0 and Ts are elevated. A thyroid scan is done, and it shows a single solitary nodule that's lighting up like a Christmas tree. It's hyperfunctioning. What's the definitive treatment for this autonomous little hormone factory?
Right, this picture suppressed TSH, high thyroid hormones, and a single hot nodule on scan points to a toxic adenoma, or sometimes called a toxic nodular goiter, TNG, if there's more than one nodule, but here it's solitary. The key word is autonomous. This nodule is making thyroid hormone all by itself. It doesn't need TSH stimulation.
So you have to get rid of it or shut it down.
Exactly. Since it's acting independently, you need a definitive treatment. For a solitary toxic nodule like this, the preferred non-invasive definitive treatment is answer A, radioactive iodine ablation, REI.
And why is REI ablation so effective and often preferred over, say, surgery in this specific situation?
It works beautifully because of the TSH suppression. Remember, the rest of her thyroid gland isn't being stimulated because her TSH is so low. So when you give the radioactive iodine, that hyperactive autonomous nodule is greedy. It sucks up almost all of the iodine dose.
Well, the normal tissue doesn't.
Right. The surrounding normal thyroid tissue is essentially dormant or suppressed, so it takes up very little of the RAI. The radioactivity then selectively destroys the overactive cells within that nodule, providing a long-term cure, usually without significantly damaging the rest of the healthy gland.
Okay, that makes sense. Let's consider the alternatives quickly. Option B, surgical thyroidectomy for everyone with this.
Well, surgery is certainly definitive, removing the nodule or the whole gland works. But it's obviously more invasive. It carries risks, like potential damage to the recurrent laryngeal nerve controlling the vocal cords or accidentally removing the nearby parathyroid glands, causing hypocalcemia. Surgery is often reserved for very large goiters causing compression symptoms, or if there's any suspicion of malignancy alongside the toxic nodule. For a clear, solitary hot nodule, RAI is generally the first-line definitive choice.
And what about just using medications long-term? Options C and D, methimazole or PTU for lifelong therapy.
Those drugs, the thionamides, are anti-thyroid agents. They work by blocking the synthesis of new thyroid hormone. So they are very effective at controlling the symptoms of hyperthyroidism, but they do absolutely nothing to address the root cause here, which is the autonomy of that nodule. It will keep trying to make hormone.
So you'd have to take the pills forever.
Pretty much, or for a very long time. As soon as you stop the drug, the hyperthyroidism comes right back because the nodule is still there and still autonomous. So while meds might be used temporarily to stabilize the patient before RAI or surgery, they are generally not considered the optimal long-term management strategy for an autonomous gland like this.
Okay, now for the absolute most acute, life-threatening thyroid scenario. 38-year-old woman. She has a known history of untreated Graves' disease. She presents acutely after a stressful event, a dental procedure with severe agitation, a high fever, 40.3 degrees C, that's about 104.5 degrees Celsius, vomiting, and extreme tachycardia. Her heart rate is 160 beats per minute, and she's hypertensive. Labs confirm severe hyperthyroidism. What is the single most important immediate pharmacological therapy she needs?
This is thyroid storm. It's a state of extreme hypermetabolism and massive sympathetic nervous system overload. The patient is essentially being poisoned by their own hormones and their body's exaggerated response to them, particularly the catecholamines. The absolute #1 immediate priority is to block those dangerous cardiac and sympathetic effects. The drug for that is answer D, propranolol.
So the beta blocker is the very first line of defense. Even before dealing with the thyroid hormone synthesis itself, it's about stabilizing the patient first.
Absolutely. You need to control that dangerously high heart rate, the agitation, the potential for arrhythmias. Propranolol does that effectively by blocking beta-adrenergic receptors. And propranolol is particularly valuable here because it actually does two important jobs.
What's the second job?
Besides blocking the immediate sympathetic effects, propranolol is one of the few beta blockers that also has a significant effect on inhibiting the peripheral conversion of T4, which is the main circulating thyroid hormone, into T3, which is the much more potent active form. So it helps reduce the active hormone load systemically as well. But the immediate life-saving effect is controlling that sympathetic surge.
Okay. Let's talk about the critical sequence of treatment here, because we know other things are needed too, like drugs to stop hormone production and release. But why is option A, giving methimazole alone, not enough for the immediate crisis?
Methimazole works by blocking the synthesis of new thyroid hormone in the gland. That's crucial for long-term control, but it does absolutely nothing for the massive amount of preformed hormone that's already circulating in the blood or stored in the thyroid gland, ready to be released. The storm is being driven by the effects of the hormone that's already out there. Methimazole doesn't touch the immediate crisis state or the severe cardiac toxicity happening right now.
Got it. And option C, using an iodine solution alone, like Lugol's iodine or SSKI, which works as a release blocker. Why is the timing of giving iodine so absolutely critical? This seems important.
Extremely critical. Iodine, in high doses, works by acutely shutting down the release of stored T4 and T3 from the thyroid gland. This is known as the Wolff-Chaikoff effect. It's very effective at quickly lowering hormone levels. However,
There's a catch.
there's a huge catch. Iodine is also the raw material the thyroid uses to make hormone. If you give a large dose of iodine before you have effectively blocked hormone synthesis with a drug like methimazole or PTU, propylthuracil, the gland can paradoxically use that sudden influx of iodine to fuel even more hormone synthesis before the release block fully kicks in. You could potentially make the situation worse initially.
So you have to block synthesis first.
Yes, the protocol is absolutely strict. You must give the synthesis blocker, like methimazole or PTU. PTU is often preferred in STORM because it also blocks peripheral T4 to T3 conversion first. Then, usually about 1 to 2 hours later, after the synthesis block is established, you give the iodine solution to block the release of the stored hormone. Giving iodine alone first is a dangerous mistake.
Wow. Okay, so the order is critical. Propranolol for immediate stabilization. Then a synthesis blocker like PTU or methimazole, then the iodine solution. What about option E, prednisone alone? Steroids are often used, right?
Yes, corticosteroids like hydrocortisone or prednisone are definitely an important part of thyroid storm management. They do several things. They reduce that peripheral conversion of T4 to T3. They provide stress dose steroid coverage because patients in STORM might have relative adrenal insufficiency due to the severe illness, and they might have some immune modulating effects in Graves' disease. But they do not provide the immediate profound antisympathetic stabilization that propranolol offers. They are supportive, essential, but not the first drug you reach for to control the heart rate and agitation.
All right, let's shift focus now to the complex interplay between mineral metabolism, specifically calcium and phosphate vitamin D, and organ failure, particularly looking at the role of the kidneys. 60-year-old man who has chronic kidney disease, CKD. He's presenting with debilitating bone pain and also significant itching, pruritus. His labs paint this really clear picture of metabolic chaos. His calcium is low, 8.0 milli-GDL. His phosphate is very high, 6.5 milli-GDL. His parathyroid hormone, PTH, level is way up. And critically, his active vitamin D, the 1025 dihydroxyvitamin G form, is low. What's driving this whole pathological process?
This is just a classic textbook presentation of secondary hyperparathyroidism, which is the main driver of what we call renal osteodystrophy, the bone disease seen in CKD. The kidney failure itself sets off this predictable four-step cascade of hormonal imbalance. The most complete mechanism described in the options is answer B. Reduced renal 1 hydroxylase activity, decreasing active vitamin D, and causing secondary hyperparathyroidism.
Okay, let's walk through those exact steps in the cascade because it perfectly connects all those abnormal lab values we saw. Where does the whole process begin in the failing kidney?
Okay, step 1. Probably the most immediate consequence of failing kidneys is that they lose their ability to excrete phosphate effectively through urine. So phosphate levels in the blood start to rise sharply. That's your high phosphate.
Step 1, high phosphate. Got it.
Step 2. The kidney is essentially the only organ in the body capable of performing the final, crucial activation step for vitamin D. Specifically, the cells in the renal tubules have an enzyme called 1-hydroxylase. In CKD, the kidney damage means you lose this enzyme activity. So, inactive vitamin D, which comes from the diet or skin, cannot be converted into the fully active form, which is 1025 dihydroxyvitamin D. That's why the active vitamin D level is low.
Okay, high phosphate, low active vitamin D. What happens next because of the low active vitamin D?
Step 3. Active vitamin D is absolutely essential for your intestines to absorb calcium from the food you eat. With low active vitamin D levels, gut absorption of calcium plummets. As a result, serum calcium levels begin to fall. That explains the low calcium lab value.
Right, and the final step involves the parathyroid glands.
Step 4. The parathyroid glands are exquisitely sensitive to both low calcium and high phosphate levels. Sensing this dangerous combination, they go into overdrive. They enter the state of almost desperation, dramatically increasing their production and release of parathyroid hormone, PTH. That's why the PTH level is so high. The parathyroid gland is frantically trying to raise the calcium level back to normal, mainly by pulling calcium out of the bones.
But that attempt to fix the calcium is what causes the bone pain and maybe contributes to the itching.
Exactly. The sustained high PTH levels while trying to compensate for the kidney failure ultimately lead to the bone disease, renal osteodystrophy, causing the pain, and can also contribute to the pruritus.
So the high PTH is purely a compensatory response to the problems originating from the kidney failure downstream. That's why we call it secondary hyperparathyroidism. It's secondary to the kidney disease.
Precisely. And that helps us rule out option A, which suggests a primary parathyroid adenoma.
Why doesn't that fit?
Well, primary hyperparathyroidism caused by a tumor in the parathyroid gland itself would also cause high PTH levels. But the key difference is the calcium. In primary hyperparathyroidism, the tumor releases PTH autonomously, which then drives calcium out of the bone and increases renal reabsorption, resulting in high calcium levels, not the low calcium we see in this CKD patient.
Okay. What about option C? Maybe the patient was taking too much vitamin D.
Excess vitamin D intake would massively increase calcium absorption from the gut, leading to high calcium. And high calcium would naturally suppress the parathyroid glands via negative feedback, resulting in low PTH levels, completely the opposite of this patient's labs.
And finally, option D, maybe it's just malabsorption of calcium for some other reason.
While severe calcium malabsorption from, say, gut disease can certainly cause low calcium and lead to secondary hyperparathyroidism, the presence of the very high phosphate level and the known history of chronic kidney disease in this case really points specifically to the renal defect, the loss of phosphate excretion, and the failure of vitamin D activation as the most comprehensive and primary driver of the entire pathological picture we're seeing here. The CKD explains everything.
All right, for a 22-year-old woman, she's got hyperglycemia, high blood sugar. She has acanthosis nigricans, that characteristic dark, velvety thickening of the skin, often in the neck and armpits. And she also has signs of hyperandrogenism, maybe hirsutism or irregular periods. Her labs show extremely elevated insulin levels, and genetic testing confirms she has a mutation in the insulin receptor itself. What's the mechanism that connects all these seemingly disparate symptoms?
This specific triad, the hyperglycemia despite high insulin, the acanthosis nigricans, and the hyperandrogenism, is the hallmark of a condition called type A insulin resistance. It's a severe form of resistance caused directly by a defect in the insulin receptor. The central mechanism linking everything is answer A: post-receptor insulin resistance, leading to hyperinsulinemia and downstream metabolic effects.
Okay, so because her insulin receptor is fundamentally broken due to the mutation, her body isn't responding properly to insulin. The pancreas senses this and tries to overcome the resistance by just pumping out massive amounts of insulin, leading to hyperinsulinemia. But how does that super high insulin level then cause the skin changes and the androgen problems?
Yeah, it's a really fascinating example of hormonal crosstalk or spillover. The extremely high levels of insulin circulating in her blood, unable to fully engage their own defective receptors to lower glucose effectively, start to bind to other highly similar receptors in different tissues. The main one here is the receptor for insulin-like growth factor 1, or IGF-1.
IGF-1 again, the same one we talked about in acromegaly.
Exactly. Insulin and IGF-1 receptors are structurally very similar. So when these huge amounts of insulin start activating IGF-1 receptors in the skin keratinocytes and fibroblasts, it stimulates their growth and proliferation, leading to that thickened, darkened skin we call acanthosis nigricans.
And in the ovaries.
Crucially, when the high insulin levels activate IGF-1 receptors and possibly even low-affinity insulin receptors in the Thundeca cells of the ovaries, it stimulates those cells to produce androgens. This leads to the clinical signs of hyperandrogenism. So the entire triad, the hyperglycemia, the skin changes, the androgen excess is a direct consequence of the body's desperate attempt to overcome the primary receptor resistance by flooding the system with insulin, which then has these unintended spillover effects on related receptors.
So that explanation neatly rules out option B, autoimmune destruction of beta cells.
Completely. That describes type 1 diabetes, where the problem is a lack of insulin production, resulting in low or absent insulin levels, not the sky-high levels seen here.
Right. And also option D, excess insulin secretion from an insulinoma.
While an insulinoma, a tumor of the beta cells, does cause inappropriately high insulin secretion, the insulin produced is functional. It works perfectly well on the body's normal receptors. Therefore, the classic presentation of an insulinoma is severe, often fasting, hypoglycemia, low blood sugar, not the hyperglycemia seen in this patient. The combination of high insulin and high glucose screams insulin resistance.
Quickly, let's shift gears now to some modern diabetes pharmacology. We have a patient with type 2 diabetes already on metformin who gets started on a new second medication. Soon after starting, he develops some mild nausea and reports feeling full much earlier during meals, early satiety. Importantly, he hasn't experienced any hypoglycemia, and the implication is that this drug might also be helping with weight, or at least not causing gain. Which class of drug fits this profile?
Okay, that combination of side effects, nausea, early satiety, which points to slowed gastric emptying combined with a very low risk of hypoglycemia and often associated weight loss. That is the absolute signature profile of the glucagon-like peptide 1 or GLP-1 receptor agonists. The correct answer here is B, exenatide, which is a well-known example of a GLP-1 receptor agonist.
Right. These drugs mimic the natural incretin hormones, the ones released from our gut after we eat. How exactly does mimicking GLP-1 lead to those specific side effects, the nausea and satiety?
GLP-1 agonists have several actions, but a major one is that they significantly slow down the rate at which the stomach empties its contents into the small intestine. This is actually beneficial for diabetes control because it blunts the sharp rise in blood sugar that typically occurs after a meal. It also contributes significantly to feeling full sooner and for longer, which is a key mechanism behind the substantial weight loss often seen with these drugs over time.
But the downside is the GI upset.
Exactly. The downside of that gastric slowing is the common side effect profile: nausea, sometimes vomiting, and that sensation of early satiety. Now, the other key feature is their low hypoglycemia risk. Why? Because their action on stimulating insulin secretion from the pancreas is highly glucose dependent. They mainly boost insulin release only when blood glucose levels are actually elevated. When glucose is normal or low, they have much less effect on insulin secretion.
Okay, that makes them quite different from older drugs. Let's exclude the major alternatives. Option C, glyburide, which is a sulfonylurea.
Sulfonylureas work by forcing the pancreas to secrete insulin regardless of the blood glucose level. This makes them effective at lowering sugar, but it carries a very high risk of causing hypoglycemia, sometimes severe. They are also typically associated with weight gain, not loss or neutrality, so completely the opposite profile.
Got it. And option E, pioglitazone, a TZD, or thiazolidinedino?
TZDs work by improving insulin sensitivity in peripheral tissues like muscle and fat. While they are effective for glucose control, they are notorious for causing side effects like fluid retention, edema, and significant weight gain. They don't typically cause the specific GI side effects of nausea and early satiety associated with GLP-1 agonists.
All right. Another patient with type 2 diabetes on metformin starts a second agent. This patient reports modest weight loss and notices they are having mild urinary frequency. Their HbA1c has improved. Which agent fits this description?
Okay, now we have a different signature side effect: urinary frequency, coupled with weight loss and glucose improvement. This pattern points directly towards the SGLT2 inhibitors. The correct answer is E, canagliflozin, which is an example of an SGLT2 inhibitor.
This mechanism seems almost elegantly simple, doesn't it? It basically works by making the kidneys dump excess glucose out of the body.
It really does. These drugs specifically block a protein called the sodium glucose cotransporter 2, or SGLT2, which is located in the proximal tubules of the kidneys. Normally, SGLT2 is responsible for reabsorbing most of the glucose that gets filtered by the kidneys back into the bloodstream.
But the drug stops that reabsorption.
Exactly. By blocking SGLT2, the drug prevents the kidneys from reclaiming that glucose. Instead, the excess glucose stays in the tubular fluid and gets excreted in the urine, a process called glucosuria.
And that glucosuria explains both the side effects.
Yes. First, glucose acts as an osmotic agent. When there's a lot of glucose in the urine, it pulls water along with it through osmosis. This leads to an increase in urine volume, which the patient perceives as urinary frequency. That's the osmotic diuresis effect. Second, urinating out all that glucose means you're literally losing calories from the body. This caloric loss directly accounts for the modest but consistent weight loss seen with this class of drugs.
Okay, let's quickly run through the others again for contrast. We already know glyburide A causes weight gain and hypoglycemia. Exonated B, the GLP-1 agonist, causes significant GI distress like nausea, not typically urinary frequency. Pioglitazone C, the TZD, causes weight gain and edema. What about sitagliptin?
Sitagliptin is a DPP-4 inhibitor. These drugs work by prolonging the action of the body's own natural incretin hormones, like GLP-1. They are generally weight neutral, maybe slight weight loss sometimes, and they have a very low risk of hypoglycemia. But they do not work by causing glucosuria, so they don't exert any direct osmotic effect in the kidney. Therefore, they wouldn't typically cause urinary frequency like the SGLT2 inhibitors do.
Okay, looking at the effects of massive catecholamine excess. We have a 45-year-old man presenting with those classic episodic symptoms: pounding headaches, palpitations, profuse sweating. He's hypertensive, and his labs confirm it. Massive elevations of plasma metanephrines and urinary catecholamines. This is clearly a pheochromocytoma. Beyond the dangerously high blood pressure, what significant metabolic consequence is most likely to be seen in this patient?
Right. A pheochromocytoma is a tumor, usually in the adrenal medulla, that's just pumping out enormous amounts of fight-or-flight hormones, primarily epinephrine and norepinephrine. These catecholamines are arguably the body's most potent counter-regulatory hormones, meaning they strongly oppose the action of insulin. The major metabolic outcome of being flooded with these hormones is a state of severe catabolism. The most likely metabolic consequence listed is hyperglycemia due to catecholamine-induced gluconeogenesis and glycogenolysis.
So the incredibly high levels of circulating catecholamines are basically overriding the body's ability to use insulin effectively, even if the pancreas is making insulin.
Absolutely. Catecholamines launch a kind of triple metabolic attack against insulin. First, they strongly stimulate the liver to generate brand new glucose from precursors like amino acids, that's gluconeogenesis. Second, they instruct the liver and muscles to break down their stored glycogen reserves into glucose, that's glycogenolysis. And third, high levels of epinephrine can actually directly inhibit insulin secretion from the pancreatic beta cells.
So more glucose production, more glucose released from stores, and potentially less insulin to handle it.
Exactly. The net effect is often uncontrolled, secondary hyperglycemia. It can be quite severe, sometimes mimicking type 1 or type 2 diabetes. In fact, many patients with undiagnosed pheochromocytoma are initially misdiagnosed as simply having new onset diabetes because their blood sugar is so high.
Okay, we dismissed the other metabolic or electrolyte abnormalities pretty quickly then. Option D, hypotension.
Clearly the opposite of the classic clinical picture. Pheos cause hypertension.
Option B, hyperpigmentation.
That's associated with excess ACTH, like in Cushing's disease or ectopic ACTH production, not with catecholamine excess. And option C, hypokalemia due to aldosterone deficiency. That seems wrong on multiple levels.
Yeah, aldosterone deficiency would lead to salt wasting, high potassium, hyperkalemia, and low blood pressure. This patient has hypertension. While severe stress from catecholamines can sometimes cause potassium shifts, often driving potassium into cells temporarily, causing hypokalemia, the primary, most direct, and most clinically significant metabolic consequence of the tumor hormones themselves is that profound insulin resistance leading to hyperglycemia.
Right. The hyperglycemia is directly driven by the catecholamines' core actions.
That was an absolutely incredible journey across the entire endocrine map, really. We didn't just, review the answers to those 15 cases. We really had to get into the weeds and dissect the molecular logic behind every single option.